Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 13, we have got Dr. Bahman Guyuron giving us an amazing talk about 40 years of being a rhinoplasty surgeon and what his top tips and traps are. Oh, Bahman, that was amazing. Thank you so much. It's to see what you packed into an hour and 15 minutes is just astounding, eh? Thank you very much. I appreciate that. Have you got some time that I can run through some questions?
Absolutely, yeah. Yes, you told me that you're going to ask me.
Fantastic. So there's lots of questions that have come in. I'm going to just go through to start off with here is, in Kenseni, would like to know, do you ever use septal extension to manage a dependent tip?
That's actually a good question. I did. Here's the problem. There are three ways that you can use septal extension graft. You can put septal extension graft just between the caudal septum and the medial crura, sutured in place. The problem is I used that initially and it shifted to one side or the other side. You can use septal extension graft and use and put a strut on one side, spread a graft on one side and suture it to one side. Then you're going to have a graft that is off the midline because it is sutured to one side. The spread graft is on one side. And I did all of that. That's why I came up with this extended spread graft bilaterally columella strut that is sitting in between those struts. There's no place for it to go. And I don't even suture the columella strut to the spread graft because I want to have a little bit of freedom, natural freedom, so there's no stiffness to the nose. I did all of that, and I came up with this. I learned from my mistakes of not being able to get predictable outcomes for the other grafts.
Thank you. Olga would like to know, what suture do you use for the supratip?
That's I should have mentioned that. You can use any suture that is on the table, essentially. I don't use permanent suture. I usually use Sixo, Vicryl, Monocryl, or if I have 5-0 chromic that I use for repair of the septum, I may use that.
Okay, thank you. Felipe would like to know, what is your advice for the use of diced cartilage or diced cartilage with fascia for dorsal augmentation on thick-skinned noses?
Well, especially for the thicker skinned noses, you need a reliable frame. I personally have never used diced cartilage graft. And the reason is I want to control. Rhinoplasty, again, I mentioned this earlier. Successful rhinoplasty is about control. When I create a frame that it has the shape that I want in the operating room, I can sleep well. I can sleep comfortably that I actually am going to see that for the rest of patient's life. When we use diced cartilage graft packed inside fascia and place it in position, I'm at the mercy of the tissues healing on their own favorably. And I just don't like that. It's not to say that it's wrong, and a lot of people have good, successful outcome, especially if I need nose elongation pending on the graft. I can't use diced cartilage because I'm going to be anchoring the base of the nose from the, or pushing the base of the nose down using the graft. So I really don't have good indicators for that. But I remember on one patient I said that I used dice cartilage. I use dice cartilage free for contouring. If I see a little small depression over the bridge of the nose at the end of the operation, that's where I'm going to use some of the cartilage that I have no other use for it, dice it and place it in that small space. That is the only time that I use dice cartilage.
Okay. Dr. Z wants to know, how do you augment the radix?
That I just lied. I just lied. That's another indication for the dice cartilage graft, because it's a depression. In a way, I didn't lie, but it is a depression. That's that's another indication that I use dice cartilage. Put it in a 1 cc insulin syringe, cut the end, and deliver it precisely in position and mold it in position. But before I do that, I make sure that I elevate the periosteum precisely the way that create a precise pocket, so it doesn't slide. The dice cartilages pieces would not migrate to the sides, widen the radix more than what I want.
Thank you. I'd like to remind all the participants that there is a survey for CME points that you can fill in. That's on the chat if you look at that. And there's also a survey we're doing on the lectures. How can we improve them? Prof, there are a lot of people just saying, oh, great, this is wonderful, wonderful. But let's get through to some more questions here. Okay, Solly would like to know, how do you quantify infratip lobule volume objectively? What is deficient and what is normal?
That's great, great choice. A great choice for you for the question. Yeah. When we look at the triangle shape of the base of the nose, we see the nostrils, we see the most anterior portion of the tip. The distance from the most anterior portion of the tip to the top of the nostrils should be around 40–45% of the entire base of the nose, meaning the nostrils should be about 55 to 60%. The lobule should be about 40 to 45%. So 55 for the nostril, 45 for the infratip lobule. So in essence, the nostrils should be the distance, the height of the nostril should be longer than the lobule on every patient.
Okay, this is an interesting question. Ali would like to know, what is your general view about preservation rhinoplasty surgery?
Anytime I have given this webinar, that question has come up. My philosophy is, number one, as I said, control. Number two, I have a difficulty preserving the part that actually is causing the aesthetic imbalance, meaning the hump. Why would I want to preserve a hump that is the reason that actually I'm doing the surgery, rather than, I mean, what are we preserving? In my view, preservation is destroying other things in an area that I don't even see, but I may not be able to control, and leaving the parts that they are the cause of surgery. Is it wrong? No, I don't think it is wrong. It's just my philosophy. I can't use septal rotation suture when the nose is deviated. I can't use extended spreader grafts when the nose is elongated. I I'm concerned about the predictability. I like to see 5 great results with 5-year follow-up. I will be 5. I'm not asking for 100. I'm asking for 5. I'm going to be convinced that I'm wrong and I should change my trust me, I have open mind about it. And I have thought a lot about it. And I've watched the surgeries. In one surgery in Lake LaGarda by somebody who's probably the most well-known individual about this technique. He was doing the surgery. Every time he tried to push the nasal bones in, the center portion popped out. He kept pushing it down, popped up, pushing it down. Finally, he gave up on the width, meaning that he stopped pushing the nasal bones together. Do I want to do that? Do I want to do that? Again, I don't think it is wrong. There could be some indications for it, but I have much more control with open technique, removing what I don't want, restoring you just saw that. I bring the upper lateral cartilages back to the midline suture, to the spread of grass, exactly where I want. So I have no reason to do it differently.
So interesting, especially with a maxillofacial background as well. And so, and I'm going to ask one more. We've got time for like 3 more questions, I think. Ahmed would like to know, do the alar contour grafts negatively affect the soft tissue triangle?
The alar rim grafts, you mean?
Yeah.
Alar contour, okay, alar rim. Yeah, actually, Roy calls it alar contour graft. Alar contour, alar rim grafts, actually, most of the time, they make it better because in a good number of patients, actually, I didn't show the cases. In a number of patients, I used to use small triangle piece of a graft in the soft triangle area at the end of the operation. Since I'm using the alar rim grafts, my indication for that has reduced significantly. Because most of the time, if you look at the secondary poorly done rhinoplasty outcomes, all of them have too much concavity to the soft triangle, and it is too depressed, and we want to bring those out. In other words, there's too much definition to the soft triangle. I do want, actually, in a properly done rhinoplasty, we do have a little bit of differential level between the end of the lobule and lateral crura. There's a little bit of soft triangle definition that is enough, that's aesthetically pleasing. I don't want to make it too concave.
Wow. Well, and that's wow, this has been fantastic, to listen to this. So I want to end off with one question for you, because there's a whole lot of different, I think a lot of young people listening from around the world as well. What would be your 3 top tips for rhinoplasty?
Unfortunately, rhinoplasty is a field that you really have to have a passion for. First thing, that if you're not passionate about rhinoplasty, I strongly suggest that you focus on other things that you're passionate about. And the reason is, unless you're passionate about it, you're not going to create good results, number 1. Number 2, learn from your mistakes, meaning you really have to watch what is working, what is not working, and document everything that you do, and go back. Make sure that you bring the patients back. If they cannot come back, have them to send you some pictures from view, profile, and basilar view. And the third element is don't give up. Don't give up. All of us, if I have a chance to redo my patients for the first 10, 15 years, I probably redo every one of them, except for a few that I showed you today. So it is an amazing thrill to get wonderful results. It transforms the patients, as you saw. And if you're a golf player, it's like a good golf shot. When you have great golf shot, when you have a good rhinoplasty outcome, but don't give up, and you will get it. You will get it. Just go after and learn from your mistakes.